It is my great pleasure to welcome Peter Hoffman. He doesn't really need an introduction to you, but suffice to say he's a consultant clinical scientist in Public Health England, and he's our expert in disinfection, sterilisation, ventilation, and a whole host of things environmental. And I'm really pleased to invite Peter to give our ALIF lecture.
Thank you, Jenny. Now, it's always an honour to be asked to give presentations at IPS, but this one is a particular honour. I knew Graham Aliff for the majority of my working life, and he influenced me a great deal by example. I had the privilege of writing this very to-the-point, word-sparse guide to disinfection in healthcare with Graham Aliff and Tina Bradley, both sadly missed. I've been taking a look at Graham Aliff's publications from the early days through the middle period, and I think this was his last one. Now, it's not just that he did good science, but he asked the right questions. That last one, deep cleaning evaluation, does it make any difference? When everyone was deep cleaning, people were asking, how do we do it? When do we do it? Very few people were asking why we do it. In order to get the most meaningful answers, you've got to ask the right questions. So, this is going to be a talk from an old man well into his anecdotage. It comes as a bit of a shock when people tell you things about the history of IPC in the long distant past, and you realise that they are part of your living experience. You get used to it. So what I want to do is to harness some of that and try and see how we've come to where we are, and maybe look at a bit of the trajectory of where we're going. Late 1980s, ENT outpatients. There was this thing. It's a Rogers Crystal nasal spray. You pump very hard on the orange bulb, and you send a profuse spray of liquid droplets up somebody's nose. This one was filled with dilute cocaine. They used that partly to reduce swelling in swollen nasal mucosa, but also to reduce the flow of blood from bleeding in the nose. Let's take a closer look at it. This was a spray that was in the ENT outpatients waiting to be used. What did we do about it? I was there with P from the hospital. We shook our heads, we tutted. Tutting had quite a significant role in IPC in those days. We removed the spray from use, and that was about it. There was very little feedback in those days. These things used to be called boiling water sterilisers. They weren't sterilisers, they were hot water disinfectors. These were in use in hospital operating theatres until maybe the early 60s. They carried on being in use in general practice as a general workhorse for heat decontamination until the late 80s, possibly early 90s. So I did a survey, I and colleagues did a survey of decontamination in general practice, and these things were in widespread use. Over half the practices visited had one of these boiling water disinfectors in use. They were in use in a fairly uncontrolled way, in uncontrolled environments. There was no good decontamination flow. These are some of the results. We were being rather diplomatic with our categorization. It really should have read satisfactory, unsatisfactory, grossly unsatisfactory. So slightly over half of the decontamination practice for high and medium risk instruments was satisfactory. Things have improved immensely since then. There's very little reprocessing of instruments occurring in general practice. Either they get instruments from a sterile supply department, or they use single-use disposables. Now, with single-use disposables, they're extremely good for the patient, but they're not good for greening the healthcare sector. So I think that's going to be one of the pressures on primary care in future, is how to operate safely and environmental conscious and with environmental considerations. Endoscopes are a big part of my life. Essentially very expensive, say about £40,000, delicate tubes with lots of long, narrow lumens going through them. The thing to focus on here is the lumen in red. This is the one that gets really mucky. It's the suction channel which removes patient body fluid from the site of interest. And also it's used for passing down accessories like biopsy forceps, taking a little bit of tissue and then pulling it and the blood that comes off it back up through that red channel. I first saw an endoscope with a colleague who was working on an endoscope, new endoscope disinfectant in the late 1970s. So we invited ourselves to have a look at a gastroscopy and just see what was going on. This is what gastroscopes looked like in the late 1970s. There were no camera chips, so the operator would put their eye to the lens there and look down and view what the fibre optic bundle was delivering as an image, and just hope that the endoscope or the glutaraldehyde had been rinsed off the endoscope properly so they didn't end up with a pickled eye. The thing that you see curled up there are biopsy forceps. One gastroscope was supplied with one pair of biopsy forceps, and they would get blunter and blunter as they were used, so they end up ripping rather than taking a nice, neat snip of tissue. They were difficult to decontaminate. Also, each gastroscope was supplied with one brush. These would gradually lose their bristles as they were used, and they would end up doing more scraping than cleaning. So the first time we ever saw a gastroscope being used, it was used in a patient, taken out. We noticed that in the box, and the endoscope was kept in the box, there was a neatly rolled up channel brush, biopsy channel brush. So we got it out and we asked them, how often do you use this? And they furrowed their brows and said, what is it? We then passed the endoscope channel brush through the biopsy channel and came out with a generous yield of organic matter. That gastroscope had never been adequately decontaminated in its life. Things have changed for the better. There's now more guidance than you could shake a stick at. 250 pages nearly of guidance on endoscope decontamination. I was part of the production of this, and all I can do is apologise. It's not the easiest guidance to navigate through, but it's there. Everything you want is there, and you just have to go hunting for what you want. There are lots of recorded outbreaks of infection via endoscopy, but very few in the UK. It's something we seem to get away with. It's not impeccable. The quality assurance of endoscope decontamination is nowhere near as high as the quality assurance of surgical instrument decontamination. But we seem to get away with it. Other areas of decontamination are less well addressed. These are transesophageal echocardiography probes. This is the first time I ever saw them. I was at a hospital for something completely different, was wandering through a room and saw these things that looked like gastroscopes gone wrong, hanging up in a cupboard, and I asked what they were. And the microbiologist who was with me told me what they were. And I went over to take a closer look. Focus in on that. This is one of my favourite photos. What I particularly like about this is the close juxtaposition of the gross blood contamination and the disinfection quality assurance sticker. So, they were very embarrassed, took that TOE probe out of use and said they would sort of address how the TOE probe decontamination was done. So, but this was general. This was an accident waiting to happen. And it happened a couple of years later. It was at one particular hospital about 200 kilometres away from where I saw this, the blood on the TOE probe, but it could have been anywhere. Decontamination of TOE probes was uniformly poor. So this was somebody who's known to have hepatitis B, had a surgical procedure with TOE. Another patient had surgical procedure with TOE. A day later, acquired the index patient's strain of Hep B virus and sadly died a few weeks later. There was an external team called in to scrutinise. Tracy Cooper, Bharat Patel and myself, we went through everything, and the most likely candidate by far for the transmission vehicle was the TOE probe. The problem with TOE probes, they should be fairly easy to decontaminate. From the probe tip to the probe handle is like a lumen-free gastroscope. Not having the lumens means it's far easier to decontaminate. The problem then starts when you get to these angulation wheels that make the tip go left, right, up, down. These are not immersible. The plug socket is not immersible. So all you can do is dangle that probe tip in disinfectant, and you've got to wipe the rest of it. Now, the people who make endoscopes make angulation wheels and plug sockets that can be immersed. It's different companies that make TOE probes, and they're using technology which means these can't be immersed. I'm sure the technology exists. There's just there's no customer demand for it. So this is about as good as TOE probe decontamination gets. These have the three elements that you need for successful decontamination. A hook. This is a magnificent hook. Most people just use a drip stand. You have a clock in order to time the decontamination steps, and you have a gloved pair of hands belonging to a trained, well-equipped operator. This is as good as it gets. And ironically, these photos are from exactly the same hospital where I saw the blood-contaminated TOE probe. So things can improve. You can get devices that enclose the handle and the angulation wheels to allow fuller immersion of the TOE probe. But all you're doing there is exposing the easy-to-get-to bits to a validated decontamination, and you're leaving the difficult bits to be manually wiped. So you can see that's the angulation wheels. That's a wipe that's been used behind and between the angulation wheels, and you can see what looks suspiciously like blood contamination. These are important. These have operator hand contact, the same gloved hands that would have contact with the bit of the TOE probe that goes into the patient. And just a reminder of blood contamination on a bit that's about a metre away from the patient, but still has operator hand contamination. Incubators are another point of interest. So we had way back, an incubator to play with. That was what was then the Central Public Health Laboratory. I got some colleagues to contaminate it with a swab of an overnight Pseudomonas aeruginosa culture. I then spent 15 minutes doing with a bucket of warm, soapy bleach, doing what I thought was going to be an impeccable decontamination. How wrong I was. I cleared 1/3 of the contamination. Over half of the contaminated sites gave profuse contamination after I did what I thought was a thorough decontamination. That was back in the 80s. What's changed? Not a lot. Staphylococcus capitis is a new bug on the block. It's become increasingly prominent in neonatal intensive care, and it's one we have got to be very wary of. It causes fairly devastating infections. It's good at transmitting, and it's probably good at transmitting using the environment as a transmission vehicle, particularly incubators. This is a group in France who are particularly interested in Staph capitis. They looked at incubators before cleaning, after cleaning, and found that over half of those incubators were still contaminated after cleaning. This is the reality of incubator decontamination. This is a fairly generous space. It's larger than many I've seen for incubator decontamination. You can just about see the person who is doing the decontamination. They have one sink, one drainer, and this lot to get through before lunchtime. Each of these incubators comes apart into multiple components, and there should then be a clear decontamination pathway from dirty through each step to clean. There's no point in decontaminating an incubator component and then putting it on a surface that you've just taken it from. It gets recontaminated. The incubator decontamination room should really be the largest room in the neonatal intensive care unit. It needs so much space, but so often it's just a design feature to be ticked off on the plans. It's just a room with a label on that says incubator decontamination room, and no consideration is given to effective decontamination of the incubators that pass through it. I think that's got to change. But that's got to change at the design stage. This is a long-term project. There's lots of problems. So these are going to be the problems for the future. And this is a short list. I could have gone on slide after slide. So this is the inside of a pulse oximeter. Pulse oximeters are always rewarding to look at. So this was ready for use. Pulse oximeters are easy to decontaminate on the outside. People forget about the inside. What do we have? Seating in showers worries me. It's fairly direct patient-to-patient transfer. And if a patient is sitting there, it's not going to get washed off in the shower. It's a little bit mucky. IT equipment in healthcare we've got to get used to. I can't see a way of routinely decontaminating IT equipment between patients. I think we've just got to treat it as dirty. Yeah, lots and lots of things. So what's going on here? What's going on here is fundamental in the design process. People design equipment to work. Decontamination comes as an afterthought if it comes at all. We're not being given much help by the regulatory powers. People who manufacture medical devices intended for reuse are obliged to provide suitable instructions for decontamination, for effective decontamination. All too often, what they produce is purely a list of chemicals that won't damage their equipment, not chemicals that are effective and not methods of decontamination by which those chemicals are going to be used. And there's very little pressure on manufacturers to produce these. There should also be pressure from the customer. If people stop buying an item because they can't decontaminate it, then that's going to be redesigned. But we're part of a world market. I believe that we have higher standards than the rest of the world, and if we say we want equipment X, but we want it modified so we can clean it, it's not going to make a dent in the market. We are too small an area of pressure to cause changes for items that are manufactured for a global market. So when was the last time you were asked by the neonatal intensive care unit about what sort of incubators they should buy? It doesn't happen. So I'm not very optimistic on progress in this area. Deep cleans. Deep cleans are a problem. They're a vital component of IPC. There's no good definition of a deep clean, nor is one really possible. You wouldn't expect, a definition would have to be so broad that it wouldn't give you detail that would differentiate the deep cleaning you would need in a neonatal intensive care unit incubator space or a care home room. These are just different. You can't have one fits all definitions. Different groups of staff are involved in a deep clean. It's not just a matter of getting the domestics in. So this is coordinating different groups of staff, making sure that each group of staff knows what they do and that nothing gets left out. And the nature of a deep clean is such, because it involves different groups of staff, that it might well be different on a Monday morning at 10 o'clock in the morning to Monday at 10 o'clock in the evening. It might well be different from Friday at 2 o'clock in the afternoon than Sunday at 2 o'clock in the afternoon. This was in the isolation room after deep cleaning following occupation by a patient with a multi-drug resistant gram-negative bacillus. Now, if you're interested in multi-drug resistant gram-negative bacilli, toilet brushes are where the action is. I don't think that toilet brush had been renewed when the room was deep cleaned. It was nobody's particular responsibility. This is a toilet brush that fell through the cracks. The next photo is what I think encompasses my view of IPC. This is a microbiologist triumphantly holding a trophy from that day's IPC hunt. This is what it's all about, and I'm very grateful to the person concerned for giving me their permission to use it. That's what a successful day's end should look like. Multi-drug, so gram-negative bacilli are going to be a big problem for the future. They were on this planet long before we were. They've got used to far bigger challenges to their longevity than we have been able to. We're a minor incursion into their world, and they are adapting to the stresses that we're putting on them fairly quickly. So they are going to be a long-term future. This is a global phenomenon. We might have good control over antibiotic use in this country, far less control over antibiotics in human medicine, in agriculture and veterinary, and also in pharmaceutical waste in the rest of the world. And these things travel. They live inside us and they live in other wet environments. This goes back to, there was a burns unit at Roehampton Hospital, just south of the river in London, and the microbiologist there, Joachim Kohn, noticed that patients who would sequentially occupy the same room would get the same gram-negative infections, and he traced it to sink waste traps. These are wet areas under a sink designed to stop sewer gases from getting out into the room the sanitary appliance serves. So there is water in there. Where there's water, you'll get microbial growth. He had a design for a device that had a heater in the waste trap, and those would boil twice a day to decontaminate the waste traps. We're going to have a problem with multi-drug resistant gram-negative bacilli in drains. The drainage in hospitals forms one continuum. There will be patches of biofilm in that continuum. Bacteria within a deep slime layer, very resistant to disinfection. Bacteria will emerge from those biofilms and swim between different patches of biofilm. So if you remove or kill one patch of biofilm, it will reform or be recolonized by different patches of biofilm. Drainage is one continuum, so the toilet over there on level 4 will be linked indirectly with the sink over there on level 2. This was a burns unit that I was going round. I was interested in the flow of water there that goes directly into the drain, and was with a couple of microbiologists observing this. And then one of my colleagues, Mike Weinbrunn, pointed at my nether regions, and there was a cry of eureka, and he'd seen that I was wearing splash disclosing trousers. So I was made to stand there and have my shame recorded for other people's education. So I'm sharing this with you. What you see there is not just clean water splashing out of a tap. It's clean water plus refluxed drain contents. This is going to be a problem for the foreseeable future. And it's not just sinks, it's showers. This is as good a photo as I could get of a shower that wasn't draining properly. So there'll be reflux of water from the drain in the shower. So the person taking the shower will be paddling in dilute drain contents. This is not good. It's particularly a problem in haematology units because patients are losing their hair. They'll lose their hair in the shower. It will go into the drain. Those drains will block, and just the unit that you don't want this to happen in, where patients are highly susceptible, it will happen. Again, I don't really have an answer to this. Each time a shower drain is cleaned by a plumber coming along and reaming it out, that will contaminate the local environment. It will contaminate the tool that they use for that. So they can then spread that contamination from room to room, and if they're contractors working at different hospitals, from hospital to hospital. This is a problem we've got to come to terms with in the future. This is about as good as the evidence gets on this. You can't do a controlled set of observations here. So this was a hospital, South London, had a problem with multi-resistant Pseudomonas. They had lots of plumbing problems. As they sorted those plumbing problems, they seemed to be a reduction in transmission of multi-drug resistant gram-negatives. We need a solution to this. Now, there have been a couple of hospitals, one in Spain and one in the Netherlands, which have greatly reduced their use of water and water sanitary appliances, hand wash basins, in the ITUs. And it seems to coincide with a reduction in the transmission of multi-resistant gram-negatives. So in Spain, they just removed sinks. In the Netherlands, they went for a completely water-free approach to patient care. Now, I think we've got to re-evaluate hand washing, particularly in the context of patient care, high dependency patient care. Most patient contacts in high dependency units are going to be with gloves. The use of gloves does not negate the need for hand hygiene, but it greatly modifies it. If there's good technique on glove donning and doffing, then hands become a less significant vehicle for transmission. Gloves, let me go off at a brief tangent. People tend to wear gloves as PPE, personal protective equipment. They tend not to wear gloves as PPE, patient protective equipment. They don't change gloves as often as they should. We have 5 moments of hand hygiene. But if gloves are worn for the most sensitive patient contacts, where are the 5 moments of glove hygiene? We don't have them. So that's gloves. But with intensive care, I'm not suggesting that we remove sinks from all UK intensive care units at the moment. But what I'm suggesting is that we keep an eye on the global literature. Maybe some brave people try removing sinks from their ITUs, and we just see the effect it has. This is a balance. Hand washing, the benefits from hand washing using sinks versus the dangers of multi-resistant gram-negative bacilli emerging from sinks and infecting patients. This is a balance that we've got to be aware of. And I suspect that waterless ITUs are the future. So, to try and sum up, I've had a very interesting career in IPC, but I came into it at the time when IPC was established, but fairly newly established, and I had the benefit of being part of a group of people who could harvest all the low-hanging fruit. There were major problems there to be solved, and by and large, those major problems have been solved. Easy problems. We're now left with a substantial group of problems which are far less easy to control. This will involve detail and context and lots of different bits of equipment and lots of seemingly intractable problems. So I think we've got to pay attention to detail from everything from TOE probes to toilet brushes. So I thank you for giving me a very interesting career, and good luck. Thank you.